You can use this to control this.
Oh, well, thank you. Great. Good afternoon, everybody. My name is Alamiri. I'm one of the nephrology critical care fellows, and I'll be talking about. I chose this journal club presentation mostly about the renal outcome in critically ill patients receiving their Propofol or Versa. A little bit of an introduction. As we all know by now, AKI is one of the major major public health problems affecting millions. We can also talk about how much it costs, especially the ICU patients, but I prefer not to. The exact incidence is very wide, ranges from 36% to 67%. For all ICU patients, they might develop AKI. We all know as well that it can increase the prolong the ICU stay and also increase the mortality and morbidity. Specifically for the ICU patient, more than general hospitalized patient, they're exposed to a lot of several kidney insults with different pathophysiology, ranging from sepsis, contrast, and also cardiac etiology. We see most often as well in this hospital hepatic etiology as well. Why did I choose this topic? Was there not enough research done or studies? Yes, but not a lot of them has been showed any difference between the results. Do we have any treatments? Well, if we have any treatments, we can just go for the Nobel Prize immediately. So no, we don't have any treatments. So what's the end point of prevention? So this is the main strategy been going on for years, is like how do we prevent AKI from developing specifically in these type of patients? So just a little bit about Propofol and the clinical outcomes. So it is associated with shorter dependence on the mechanical ventilation and the ICU length of stay. There's been meta-analysis done for that. It has anti-inflammatory and immunomodulatory properties been shown in studies, specifically as we see in animal modules. And that also has been shown that decreased incidence of AKI as well. Propofol is associated with reduction in AKI incidence in patients undergoing valvular heart surgery compared to sevoflurane anesthesia. So this study was done in China, and it was published last year, 2014, in the Kidney International Journal. And basically, that is why they did this study. When they see the result of that study, they decided that this study will be might be of benefit. So this is.
Sorry. Might be of benefit in medical or surgical
ICU patients. Yep. So this is the study. It was the renal outcomes in critically ill patients receiving Propofol or midazolam. So a little bit about the study. So it is a retrospective cohort study. So the data source, it was brought in from Multi-Parameter Intelligent Monitor and Intensive Care Project. So what is this? This is just a project or a data source in MIT that collects all the information for all ICU patients from 2001 to 2008 at Beth Israel Hospital. So we have a lot of data, and they collected numerous data ranging from blood pressure, who received specific medications, their vasopressors. A lot of data has been collected. The criteria to be included in this study, they looked at all vented patients receiving Propofol or Versed for at least 6 hours in the first 48 hours after ICU admission. They excluded end-stage renal disease. They excluded anyone who received dialysis before the ICU, anyone who had insufficient labs, anyone who stayed less than 24 hours, or any serum creatinine more than 4. By definition, that's AKI stage 3. We'll talk about it later as well. Or any patient who received Propofol and Versed at the same time. This is the definition of AKI. This is the KDIGO guidelines, and this is what we all go with it. So it makes the AKI, or stages the AKI to 3 stages. We rarely use the rifle criteria now. So for stage 1, commonly a lot of people use that if we see any increase in the more than 0.3 milligram per deciliter from the baseline, but we usually prefer to look at the 1.5 to 1.9 times the baseline. Or you can also look at the urine output which is less than 0.5 ml per kg per hour for 6 to 12 hours. Stage 2, this is a lot. We see this more common also in the ICU. 2 to almost 3 times from baseline. AKI stage 3 times the baseline, or they become automatically stage 3 if you have an increase of serum creatinine more than 4, or if they receive dialysis, or of course in pediatric patients less than 18 with GFR less than 35. And also we can look at the urine output ranging from the timing as well, less than 0.5 from 6 to 12 hours, more than 12 hours, and AKI stage 3, and uric more than 12 hours or less than 0.3 for more than 24 hours. So how did they define AKI in this study? Any ICU patient, they have this, they're special patients, so we can't really be specific about our patients. So what they did, they looked at the first serum creatinine measured available after the ICU admission. So that was the baseline. So if they came with an AKI stage 1, they took it as a baseline. So if they developed AKI or they became the AKI worsened, then that will be of note. So they were classified based on the KDIGO guidelines that we just saw, and the maximum stage achieved during the first 7 days. So they followed the patients for the first 7 days in the ICU. Whoever received dialysis during this period were considered AKI stage 3, as the guidelines mentioned. So what outcome did they look at? They want to see the worsening or development of AKI from the KDIGO guidelines, either looking at the serum creatinine or urine output. They looked at patients who develop oliguria. Any diuretic use, we do that all the time in the ICU. We just say, let's just challenge the kidney and see if they respond. Any cumulative fluid balance, so any patient who developed positive fluid balance. Anyone who received dialysis, any form of dialysis. They looked at the length of stay and the mortality. So from the data we had a total of almost 33,000 patients. Looking at the adults, we had 24,500. They excluded anyone who, as we said, less than 24 hours. They excluded the ESRD patients. As we can see, almost 1,700, they had insufficient data. 800 patients received both the Propofol and the Versed in the first 48 hours, and 9,000 patients were without Propofol or Versed in the first 40 hours. So we had a total of 8,834 patients that met this criteria, which is a pretty significant number. So as I said earlier, this is a retrospective cohort study. But what they did is they did the propensity score matching technique, and they used it to achieve a balance of the measured baseline patient. So what does that mean basically is that, as we all know, the cohort study can have a bias and confounding bias. That's what happens when we look at all the data from the before. But when we have a specific variety, or we bring two patients or two sets of patients with specific variety and just compare them to each other, this is what we call the matching technique. So they will not look at any patient receiving Propofol. You have to have the same characteristic or same disease or variety receiving these two drugs, which I will show now in this table. So if we look at all these variables, there's a lot of it, ranging from hypertension. We see that congestive heart failure, COPD, liver disease. Also, we look at what kind of admission, was it ER or they came from the floor? What ICU service, medical, surgical, cardiac, sepsis, and we can also see their map. They looked at the map, who need pressors in the first 48 hours. And they also looked at the nephrotoxin, the drug contrast, and also it depends on mechanical ventilation. So when we look at the unmatched cohort, I don't know, is this working? Okay. When we look at the unmatched, we see that we have a total of 8,000 patients receive Propofol and only 740 patients receive Versed. So we see there's a big difference going on with all these variables. But when we do the matching and make sure that both patients, when we compare them, have the same variables, we see all the significance disappear. So we had almost like, if we look at the, let's say, take, for example, the liver disease, you had 170 patients or 24 patients, and all compared to 26. Non-clinically significant. So that was a strong point about this study. So we'll talk about how much patient did they receive. So the mean infusion dose for the Propofol was 35.3 mics per gram per minute, compared to 0.8 mics per gram per minute for the Versed. Almost 80% in both did not have any interruption in the first 72 hours. And as we all used fentanyl and morphine as well, they had been used, but they were clinically insignificant after the first 48 hours. They were with an average 8.8 for the fentanyl in the Propofol group, and 8.3 fentanyl in the Versed group, with the morphine as well, ranging from 16 to in the Propofol group and 19 in the Versed group. As I said, they were not clinically significant. So this is the main slide, basically. So this is the results. So if we're looking at the Propofol group patients, and we compare to the Versed group patient. So the first outcome that we talked about is developing any stage of AKI. So if we look specifically at the AKI stage 2 and 3, there were clinically significant difference in what basically in the odds ratio in patients on Propofol developing AKI compared to Versed. So we had less chance of developing AKI if you were on Propofol compared to Versed. That's exactly what it means. And they also did adjusted odds ratio, which basically means they adjusted for the aminoglycosides and sepsis. And they also showed there was significant difference with odds ratio of less than 1 in both, with 0.6 and 0.6 for stage 2 and 3. Other outcome was the oliguria. Less likely to develop oliguria if you were on the Propofol compared to on the Versed. And diuretic use. There were less use of diuretics in the Propofol matched patients compared to the Versed matched patient. And the cumulative fluid balance was more than 5%. That's the cutoff that they used because they were only looking for patients the first week. So they had a lower cutoff for the positive fluid balance. But they also showed the significant difference between the Propofol treated patient compared to the Versed. So they were less likely to develop a positive fluid balance. In regards of dialysis or renal replacement therapy, it wasn't clinically significant, but it was a trend of less use of Propofol if you were in the Propofol group compared to the Versed group. Only a trend, but not clinically significant. In regard of the mortality, which we all really like to hear, there was a clinical significance difference between the Propofol patients or Propofol matched patients compared to the Versed matched patient as well. And this is also about the length of stay. It wasn't included in the table, but it also the study did show reduced ICU length of stay in Propofol treated patients, 8 compared to 9 days. It wasn't significant, but it was only a trend. So this is also just to show that the incidence of AKI. So no AKI was developed in the older Propofol patient. These are the Propofol patient compared to the Versed received patient. In AKI stage 1, they noticed that it wasn't clinically significant, but there was also more AKI developed in Propofol. But in the more severe form of AKI, AKI stage 2 and 3 were more seen in patients who received Versed compared to patients who received Propofol. On top of the matching, which makes this study more sensitive, they did another sensitivity analysis. So they, as we said earlier, they looked at all the serum creatinine. First, serum creatinine measured in the ICU admission. But if you have already developed AKI or you had CKD, so that's exactly what they did. They removed all these patients and they looked only on the normal patients who never had any abnormal serum creatinine on admission. Still, there was clinical difference for AKI development in patients who were on Propofol compared to the Versed. Less likely to develop oliguria in patients on the Propofol compared to Versed. Less diuretic used on Propofol matched patient compared to the Versed. Less likely to have positive fluid balance as well. And still no clinical significance and the dialysis need. But there was also a significant difference in the mortality of the ICU for the Propofol compared to the Versed. So another one was performed excluding all patients who underwent cardiac surgery. So they also found similar findings. So where the strength of the study comes from? So they evaluated a large and detailed database of critical care patients. As we said, they started with 33,000 almost, and they end up with 8,000. And we saw the extensive matching system or characteristic to increase the reliability of the reported outcome, including the use of either hemodynamics, the map, or use of also the pressors. But it's a single center data study. So why is that a weakness? Well, I don't know how they practice over there. That's the first. But it's also better to have the same outcome in different centers. They always make this the study stronger. It's a retrospective study. So regardless of how much we try to do the matching, there's a chance of having a confounding factor or bias. Patients with sepsis were only about 20% in this matched group. So if you ask me if does this Propofol also include all the patients, no, I can tell you that Propofol has been shown better for generalized ICU patients, but specifically for sepsis, I cannot answer that question. And also the absence of information about nephrotoxin substance administration before the ICU. We have only during the ICU stay ranging from contrast to nephrotoxin medication, but not before the ICU admission. So this is in summary, in this retrospective cohort study in ICU patients, Propofol was associated with statistically lower risk of developing AKI and several other important renal related outcomes, as we mentioned, when compared to midazolam. Any questions?
Did you mention that didn't change mortality and
Length of stay?
did not change?
It did change. Mortality changed. Length of stay was showing trend to decrease.
And renal replacement therapy did not?
No, just the trend to decrease, but it wasn't clinically significant. No, and we can explain that. But if you're going to develop a symptom, I mean, as you pretty sure know by now, it's ranging from.
No, it was significant. Go back.
Because
No,
the
it
odds
was-
ratio was, and the confidence interval were less than 1.
So if we see the odds ratio and
Not this, the one before this one right there.
So RRT is 0.03.
it was like
It's 0.24
trending.
to 0.96.
Yeah.
So this,
Yeah.
Mhm.
He was talking about.
No,
go ahead. No, it's not. Just saying what he meant was there's a trend towards reduced ICU length of stay. That's it, but the RRTs.
So they showed diuretic use as an outcome. Did they say, I didn't see this when I read it, did they say that it's an outcome? How do they define it as an outcome as opposed to a risk factor?
No, when they, I'm not sure I understood the question, but when they looked at the outcome, they want to see who used it and how much they used it. They didn't look at it. Let me go back and see the characteristic. They didn't look at patients who had more diuretic use as the characteristic as development AKI. Is that your question?
But no, but the patient, but in fact, so the patients who got midazolam had more diuretic use.
Mm-hmm.
So why can't you say that the reason they had worse renal outcomes was because they had more diuretic use?
Yeah, I mean, if you
No, the fluid balance was different.
then it goes with versus. If you have more fluid balance, you need to challenge your kidney more. So they use more diuretics in these patients.
It's hard. It's
So
hard
it's
to figure
difficult.
it out though, but you can also look at it. Do you want to try to answer the question? I'll say.
Yeah, I mean, it is right that definitely diuretic I can let you have the AKI. They didn't comment specific on that, but if you have, the way I can see it is like if you're having more positive fluid balance, you need to get out first. You will challenge the kidney, so that's why you're having more diuretic use in the Versa group. You have more fluid balance. That's why you need more diuretics. But did they use diuretics before developing the AKI? They did not look into that.
Right, that's my question.
Yeah, they did not look into that.
He's on this too.
Yeah.
Is there this?
noticed that the Propofol group before they were matched was 8,000 and the first set was 700. Is there, when they did the retrospective review, did they look at the dates, like did they change to a new protocol later and then Versed is like 2 years ago?
No, I don't. No, they don't look into that.
Why would it be 8,000?
Yeah, that's the one. That's the one thing in the study as well that. Regardless from all the 8,000 patients, most of them were propofol used. I mean, that might be also one of the limitations of the study. They have less, despite the match, we have less population of Versed patient compared to propofol, but they didn't show any.
I'm just wondering if that indicates something that's not in part of the cofactors. Cofactors seem pretty good.
I mean, they matched on 20. So this is a actually theoretically at least you can call this a prospective cohort. The reason is all the information gets collected on daily basis, so that you can consider all these things exposure, and your outcome is happening later. Theoretically, this is a rich database that everybody can access if you request it and put in an IRB. I mean, it's for the sake of the publication.
It is free for the public, yes.
All the data, it's not like they decided in 2015, let's see the sepsis incidence, which patient has sepsis. So,
I'm just curious, like, I wonder if it's not an article. Why does this place basically uses propofol for preventive patients, except for a small minority?
I have colleagues in a lot
Yeah.
of places that use propofol.
I know, but I'm wondering if there's something, what is it different about why the doctors decide to use first for these patients when the hospital obviously likes to use propofol?
So the notice that when you look at it, why do you have a lot of propofol? What I notice is also that you have before matching, a lot of CI patients, cardiac patients as well. And CI patients, they use a lot of propofol more than the Versed as well. So that might be a cofactor as well, why they have more propofol patients if you don't have MI. And then other than that, they didn't comment on
I think
it.
to Jeff's point, I mean, if we had 10 intensivists who all like to use volume ventilation, and we have 11th who likes to use pressure, once you use that as your marker, there's going to be a whole bunch of other things that one physician does that you might not measure that could lead to outcomes that have nothing to do with the fact that they use pressure ventilation.
Like
so
using extra laces.
you have, I mean, because like in the medical ICU, even there, right, you have 2,300 patients getting propofol and 300 getting midazolam. There has to be some reason why those 300 patients got midazolam, either because they're admitted to a doctor who likes to use midazolam, or they had some other thing that caused people to use midazolam.
You could look at it as a limitation, but also where you can look at it that this is actually more proof that why propofol is good, because you have more patients using propofol, yet less likely to develop ACI. You have less patient who is using Versed or Versed being used.
No,
Right. So the issue is, again, is the question of, is that a random allocation? If it's a random allocation, then all of it is valid. The question is it really random?
It's a retrospective. It's not random. It's difficult to make random.
No. But can it be?
Can I just
Can the things that you've measured? Is it likely that there's a significant unmeasured confounder that is causing the renal failure that has nothing to do with midazolam? Is ultimately the question.
Of course.
I mean, it's a cohort. It's not a randomized retrospective, but I guess it's a possible.
It would seem stronger if
they had this,
if 3,000, well, if 5,000 patients got propofol and 3,000 patients got midazolam, it would strike me that would be more likely to be random than if it's such a big difference.
One of the limitations also they say if you're going to look at the article that also that there were less number of patients were received Versed. So you're right. The higher number of Versed patients, they will make the study more strong. Yes, Doctor.
The answer is there. The bulk of the patients who received propofol, not only in terms of percentage but number, were surgical patients. So these are the surgical patients are contributing the most to that 8,000 patients of Propofol. You see the percentage or so. They're contributing 4,832.
But the ratio of propofol to midazolam is about the same in the medical unit as it is in the surgical unit. There are about twice as many midazolam patients in the medical unit, and there's about, oh, I'm sorry, it's half. So you're
Yeah,
right.
so that's why. That's what's driving it. That's
But
why
it's still
they
a
did the
very
trial.
large difference.
Of course, there is, but so the bulk of surgical patients are contributing to the data. Then what you have to do is you have to match at least on that. And when you look at the right column, you look, if you look at the percentages, they're 18.8 and 21.9. Having said that, even if we do the propensity, I think in terms of taking care of that surgical problem, that difference, that's what you do. You have to adjust it. So they use propensity score matching, not only adjusting for that, obviously for other things, but that's the only way you go about it. Now the question is, do I feel, the question is, does Propofol cause less AKI than Versed in an ICU patient, or Propofol or Versed is more likely to cause more AKI? In general, the data, there is enough animal data that for a while they've been suggesting that, but there was not a single study in ICU patients evaluating that. Now, what strikes me more though is also there was a trend, or a lot of difference in ICU mortality as well, which kind of is hard for me to explain unless the mortality is also driven by the AKI.
You could explain the mortality being driven by delirium too.
Yeah,
There's less
but,
delirium in
for me, like,
propofol.
I can find an explanation why propofol is less, less likely to cause AKI, but overall how it can affect mortality, I don't have an explanation. Now this is C. Jason, by the way, so it's equivalent of chest. So
How can we go back to the previous?
in nephrology.
Because there have been a role in, so if you look over there, the chloride distribution fusion per 7 day of ICU stay was also less in the
Look at the right
Propofol,
You have to look at the right two columns, the adjustment.
the match cohort.
It's matched cohort. So basically what they're doing is finding somebody who has all these characteristics. He's about 66. He's about almost a male. It's male. Hypertension, he has it. So each patient almost has all these characteristics, and they find, that's why you have a big cohort to choose from. So they have for each patient to look in 10 other patients in the other group to find somebody that almost has all these characteristics, not all. But each patient gets a score for all these characteristics, and then they get the same score. Now, having said that, even after you do the total matching, like any clinical trial, you still might find a little bit of difference between the patients. And if you see something like that, even after propensity matching, you can still try to adjust one more step, after that in this, another regression analysis.
Yep. What do you?
I have a question. I was thinking about that.
Is the
I was thinking about that. That was my question. Shooting off from Dr. Yesayan was, is midazolam nephrotoxic, or is propofol prevent the unmeasured events? Just a second, I haven't thrown my question. So, or propofol actually is a renal protectant. So, my question is, my secondary question is, why did they choose midazolam to compare with propofol? And if the theory based on your introduction is propofol has some immunomodulatory effect, why did they not design a study on just adding propofol and letting the rest ride the fentanyl?
design?
Not design, but look at patients who didn't get any sedatives. Is
Right.
what you're asking.
You can exactly. I cannot answer this question. They're the one that decided. But you're right. Propofol has been shown in animals that is promodulatory. It has anti-inflammatory effect as well. In this data, they say a lot of patients did not receive any sedation. So
everybody got it.
no.
So
I can show. See, you have 9,000 patients without propofol or Versed in the first 48 hours. I mean, this data is for public. You can just sign the release form and get whatever the whole
Let's
IRB
do it.
thing, and then you can do it and see who also has fentanyl.
It wouldn't be hard, it really
No.
is easy
Yeah,
to do.
because, I mean, that would be, I
It's
think,
not easy.
This
Just playing with numbers,
Yep.
running some stats code. The question would be, so if you saw that study, would you believe that the difference is the fact that they got propofol or didn't get propofol, or is the difference the fact that patients who don't need sedation are likely to do better?
okay.
And that's what's hard about any retrospective study, is trying to differentiate confounding by indication from an effect that is truly random.
So, I mean, so this is what I would take from this data. And if you tell me, like a lot of times I don't use propofol because in my mind, I always worry about hypotension, AKI, propofol infusion syndrome, and so forth. If I see this data, I'm not gonna say propofol personally, that propofol causes less AKI. I'm not pretty sure of that, but I feel, more comfortable using propofol in the ICU right now instead of Versed. But I would not come and tell you, I feel strongly that it's going to cause less severe AKI. You need a clinical trial at the end to conclusively say so. Many times you need more than one clinical trial. We're still doing clinical trials about mucomas. I'm serious. But if the signal is so strong, I mean, what you can see here is the signal is pretty strong. The signal is pretty strong, and you're also seeing the, there's also, not only as an AKI as a whole, there's a signal that, it's going upwards, more severe AKI, more common as well, then perhaps it is true. Perhaps.
They didn't look at the episodes of delirium in both arms, right?
Well, it wasn't documented. They didn't look at it here. No. Yes.
Is it a positive point? I know about the matching, and if you look to the right two columns, you find the three columns, right? You find the matching. But is it a strong point for such a study that it combined both medical, surgical, and cardiac surgery and cardiac care patients in one study, or was it better to stratify into 4 studies? Like the reason for acute kidney injury in cardiac surgery, ICU in the first 24 hours might be different than the etiology in a medical ICU.
If you look at the just outline. No, I'm just saying, they look at the whole critical illness. They look at all ICU patients. They didn't specifically say any patients in any specific unit. And the numbers, if you look at it, actually have more MI patients than CI patients or SI patients.
No, I'm saying, if you take this same data and do the calculation only on the medical ICU patients in such a big center and apply it to all big centers with such, like we know how we admit
you can
ICU and what's the criteria compared to SICU, CICU, and surgery. Is that gonna add a stronger point to the data you have?
It will add if you can do it. If you look at just the MI, I mean, you never know unless you do it.
The answer for that is if you can. So if you do in medical, the conclusion is going to be in medical ICU patients. And if you do it in cardiothoracic, I'm not, I'm coming to what I'm going to say. But the problem on top of that right now is if you look at the patients, to do propensity matching is very costly. You have to pay a price by, losing a lot of patients who fulfill a lot of these characteristics, or who can fulfill the score that is given to each patient so that they are equal. So if you're, for example, doing in only cardiac surgery patients, which is a very good, you're not going to be able to match on all these. If you look at the cardiac surgery patients, in one group you have midazolam 15 people, cardiac surgery 557, so you're not going to be able to match.
But what do you mean when you do in the match, there are 15 and 15? In the match column,
I know.
there are very similar numbers. They match only the
Yeah, this is the number of the patients who had cardiac surgery So you have 15 patients who had cardiac surgery received propofol, 15 patients who had cardiac surgery received Versed. Not all the 15 had all of these variables. So you might have only 15 will receive the same received cardiac surgery. So you might lose diabetes, you might lose liver disease, you might lose obesity, you might lose use of vasoactive. So you will lose other variables that were important in the study. Mm-hmm.
So let's assume, no, it's a good question. It's an excellent question.
Mm-hmm.
So if you have only these patients, like let's say the 557, only to start with, that's your total cohort, okay? And then you divide them to propofol and midazolam, and then you do this, you try to match them. You might not be able to match them. You're going to see a lot of p-values that are different despite your efforts. That's all what I'm trying to say. Can you do that? Yes, but you know, even in logistic regression, let's say assessing mortality in two groups retrospectively, and I have a lot of variables I want to adjust for. And let's say only 10 people died. If only 10 people died, the number of events is 10, you know, I can only adjust for one variable approximately. Okay, you need a lot of events for you to be able to add adjustment for everything. So the same thing happens here. If you start with less number of patients, you know, that you're going to lose a lot of patients, but you can perhaps answer a question, but you're not going to be able to do a propensity analysis. Propensity analysis needs a lot of data. You cannot do it in 500 patients and adjust for all these. It's impossible.
So I thought that you took all the 15 patients on midazolam in the cardiac ICU, and all the patients, okay,
No,
557 of propofol, 15 of midazolam. I thought that in matching, you took all the 15 on midazolam
That is
and
correct.
matched them to all the patients similar to them on the propofol group.
Well, no. So the patients will not be, so the patients
Score.
you get a score.
Yeah.
And the score ends up distributing them in a very fair way. And in general, you end up with values that are not different. You can still have difference. You know, it's a score. It's like you make it the way the clinical trial. I can have random, completely random, randomized trial, and at the end you run the basic characteristics. They still might be different, not in every variable, but there is actually, you know, 5%. If you're looking at 100 characteristics, you know, there might be 5 to 10% of them that are different. And if those baseline characteristics are related to the outcome, then you're in a problem. You know, even though it's a clinical trial, they might tell you, yes, you did it completely random, but you ended up patients who were on propofol, you were also giving them a magic drug, even in a clinical trial. So if that happens, then you have on top to try to do statistical adjustment on top of your clinical trial. The same thing here. But coming back to it, I mean, there's no end to the questions you can ask. Can it be in cardiac aortic surgery? It may be, yes. I mean, this only answers you in a group of patients who are admitted to the ICU. Perhaps there's a signal for less AKI with propofol use, you know.
Paula, did you get your question addressed? I don't know.
I think the only way to do it is to take two identical twins who are going into a surgery. No, honestly, my thinking was the 15 patients on midazolam, like all of them have diabetes, chronic kidney disease, chronic liver disorder, and
it's impossible.
It's impossible, but they match them to the closest they can.
Yes,
So they match. So the idea of propensity matching is that they're saying for each patient in the study, for all 9,000 patients, they're saying what is this patient's risk of getting propofol? So you can, based on a variety of things you know about that patient, you say they have a 80% risk of being on propofol. So if you find a patient who got midazolam who had an 80% risk of getting propofol, and then you get one patient who had an 80% risk of getting propofol, who got propofol. Then the second patient had a 20% risk of getting propofol. That patient got midazolam. You find another patient who had a 20% risk of getting propofol, but that patient got propofol. And you match them. And you do that 698 times. And it just so happens then when you've done all that and you look at the groups look very much the same. But you're not matching, you're not finding a COPD patient and matching them to another COPD
who has
patient.
congestive heart failure or doesn't.
You're just finding a patient who has a risk of getting propofol. And you're finding another patient who has that same risk within, I think they said within a standard deviation of that risk score. And that's how you do propensity score matching. So at the end, in theory, if you've measured every important variable, you have two patients who have equal risk of getting propofol, one of whom got propofol and one of whom got midazolam.
Question on that.
Yeah.
Would they look at the risk to get propofol, or would they just put them into a propofol and midazolam group and have each one of these as a category or risk stratification and say this person has this, according to all these, they like numerically put a risk for each one of these and say this person in the midazolam group has a risk of 89 and this person in the propofol group has 89 and then put them as that?
No, so they really do say you run a score like if you're trying to develop a prediction score for PE, right, for an outcome. Except now you're looking for a prediction score for an exposure. So you're saying here are all these 9,000 patients. How likely are they to get propofol? And you put in that equation everything that predicts the likelihood that you're going to get propofol.